Hello, I'm John Clymer, Executive Director of the National Forum for Heart Disease and Stroke Prevention. And the conversation that you're joining today is part of the Value and Access Collaborative series examining how we move from cardiovascular risk screening to evidence-based care that improves outcomes. I'm pleased to be with Dr. Mike Cropp, who is a family physician and the president and chief executive officer of Independent Health, a nonprofit health plan with a strong focus on population health. Under Dr. Cropp's leadership, the organization delivers products and services that improve the health of almost 375,000 customers in Western New York State and has been consistently recognized nationally for excellence in quality service and innovation. Dr. Cropp, welcome.
Thank you, John. Great to be with you.
Thank you. Let's get right to it, Dr. Cropp, because you bring both clinical and payer perspectives. I'm really excited to explore with you, to hear from you how health plans can help close the gap between identifying cardiovascular risk and helping patients get the evidence-based care that will help them reduce their risk or manage it. So let's begin with your perspective from as a health plan CEO. How significant is the challenge of cardiovascular disease today?
I would say it's the most significant challenge that we face because when you think about cardiovascular disease and the risk factors and the sequela, it's having a huge impact on the health and well-being of the population and the community that we serve.
And so it's big. And when you look at the landscape from your vantage point, and in this case, it's a covered population, one that has healthcare coverage. Where do you see the biggest gaps between screening and diagnosis and then treatment and management?
Um, we take care of members that come at us through four different mechanisms. We have a Medicaid population, we have a Medicare population, a commercial population that's fully insured, and then self-insured is the fourth. And clearly, the biggest challenges that we see are with the Medicaid population in that their access to care isn't quite as open as it is with the other populations that we serve. And the resources that they have are typically somewhat constrained as well. So when I look across the four different populations, clearly the biggest challenge is in the Medicaid population, but the biggest impact that we see is in the Medicare population because they have years and years of these risk factors that haven't been well managed that we're now seeing them with various forms of cardiovascular, renal, and other diseases that if we had better treatment we would not be seeing the kind of prevalence that we're seeing for these chronic conditions.
So it's a cardiovascular disease, highly prevalent, a big problem, and patients are facing a lot of obstacles. People aren't receiving
Right.
timely care
Yeah,
that would help to reduce the burden. Is that right?
that's correct. And I wish I could tell you an answer to this, but I can't tell you how many of our population would have risk factors and not be aware of it at this point. Particularly with hypertension. I would venture a guess that it's a pretty significant number of folks across all of the populations that we serve that have hypertension, that don't know about it, and then at the next level that have hypertension that isn't well controlled.
Hmm. So let's take that first set of people, Dr. Cropp. Why don't they know?
I think that it's has to do in some populations with the access. And in other populations, it's kind of perhaps written off by the docs. They come into the office, the blood pressure may be high, and they don't see the doc all that often. And so the doc might write it off as say, well, that's white coat hypertension. I'm sure that's not your normal status. And and so given, what docs are faced with, particularly primary care docs, and the limited time that they feel they have, often something like this just might not get a full look.
So I'm hearing about the time that um, clinicians have with their patients, and then the attention that patients themselves are paying. And I think there's a reason that hypertension, high blood pressure is called a silent killer.
Yeah.
It's not waving a flag in front of anybody's face. They're not having to, buy a bigger belt to accommodate it. So what's some of those? Well, we're talking about both
Well,
social factors, we're talking about structural system factors. Dr. Cropp, how good is the alignment between the healthcare system and optimal cardiovascular outcomes?
John, I was going to come in with this point that there are studies that if we go back into the 50s and the 60s, looking at health, work site health clinics. And I can't remember the employers. I think Westinghouse might have been one of them. But when nurses were charged with managing blood pressure for a workforce, they did a far better job of getting people to control than those patients who just went to physicians. And, I think about, that white coat hypertension thought and the fact that, physicians were human and somebody comes in and we don't see them that often and they have elevated blood pressure. And you might find out that they've been under stress at work or there's just a major event in their life. And so you write it off. Um, and until the next time, who knows what's going to bring them into the office the next time. But when nurses were charged with getting people's blood pressures to targets, they didn't take any excuses. That was their job to get them to target. And, I think that there's an opportunity for us to take a look back and see some of these things that have worked in the past and think about the current healthcare workforce and how can we deploy people differently and learn from those past lessons to get some better control.
So we know that one of the challenges that we face as a nation today is that we don't have enough primary care providers. Um, would the kind of thing that you're suggesting possibly help not only with bringing high blood pressure under control and helping to reduce that burden, but maybe also partly solving that shortage of clinicians?
It conceivably could. I think that, hypertension could be amenable to control by other members of the team. Even community health workers, I think, have been shown in other settings to be able to be effective in helping people understand and better treat their blood pressure. And I think that we're now beginning to see some things with diabetes that can extend the reach beyond the primary care physician as well. And so um, both the human element of the extended healthcare workforce and then the use of modern technology, I think both of those are capabilities that we should be exploring to broaden the reach and extend the capacity of primary care by doing so. Yep.
Can you expand on that just a little?
Yeah, so my favorite sort of topic on this is not hypertension so much as diabetes, because we know that diabetes is a significant risk factor for cardiovascular disease. And today in the United States, 1 in 10 adults have diabetes, and 3 in 10 are pre-diabetic. And the typical way that we used to treat people with diabetes is we would see them once every 3 months. And if their blood sugar, their glycosylated hemoglobin was not under control, we'd have to, oh my God, what happened over these ensuing 3 months? What did they eat? What, and what was their physical activity like? What was their stress level? What did their sleep? And impossible. The best sort of diabetic patients would come in with sheets of what their blood sugars were. And I couldn't make heads or tails out of 3 months worth of data, not to mention what do they eat and everything else. Now, there are tools, and we've used a tool now for about 8 years called Brook that allows people to capture the information about their blood sugar, integrate it with the other things in terms of diet, sleep, exercise, and and have the machine learning interact with the individuals in the moment. If they didn't sleep well, what might they need to do in terms of their physical activity? Or if they're at the supermarket and they got to make a choice about this kind of protein bar, which one is best for my diabetes? That could never happen, before. But now we've got the technology that can do that. And the technology can also integrate that information such that the patient can see the correlations between the dietary changes, physical activity, the sleep, and that information can be integrated and shared with the doc. And the doc can now have an informed conversation that says, on those days when you get 7,000 steps, your blood sugar is consistently better. Let's set a goal for the next 3 months to do that. And so what used to be a very challenging conversation to try and integrate all this information. Well, now it comes to you. That can be just part of the interaction, and you can use the rest of the interaction to do more conversation with the patient and come away with an agreed upon set of actions for the next 3 month period. And that dramatically opens up the primary care capacity by smart use of technology. So
Yeah, so the technology that you're describing, if I'm hearing you accurately, it's putting a lot more data at your fingertips, and it's saving you as a clinician a significant amount of time that then instead of trying to figure out what's on the piece of paper, you can apply that time to shared decision making with the patient. Is
exactly.
that
That's exactly right. And it works. It provides information to the patient that they need when they need it, and it provides the kind of information to the physician that you just described in a way that's more meaningful and actionable and time saving. Yep.
And then, Mike, I read a study by your friend Karen Margolis and some of her colleagues that compared team-based or telehealth to in-clinic care for hypertension or blood pressure management, and they found there's no difference.
Yeah.
The telehealth was equally effective. So is that another way that we can, one, reach more people and two, gain efficiency in the system?
Absolutely. Absolutely, John. I think that the capabilities of doing the remote patient monitoring to monitor blood pressure have become very reasonable, very accessible. And I think that almost foolproof in terms of people being able to use it as well. So it's become quite reliable And as you point out, it becomes an easy extension of capacity for folks who have hypertension and eases the burden on primary care. Yep.
Yeah. Okay. I
Yeah.
want to change directions for just a moment. We'll come back or we'll tie this in a minute, I suspect. But Dr. Cropp, how does the current structure, the current reimbursement and incentive structures, how do they influence cardiovascular disease and metabolic prevention and treatment efforts?
The traditional methodology of paying providers a fee for service obviously hasn't worked. The results speak for themselves. Moving to um, more value-based care and payment models can be very effective. And that is what we have seen in our experience here at Independent Health. And so when we recognize that there are services that typically had not been reimbursable in a fee-for-service world, email, telephonic visits, more visits with a pharmacist or nurse visits. Those things just didn't get reimbursed in a fee-for-service model. And yet we know that some of those activities can have a hugely positive impact on folks with hypertension or diabetes and bringing them to control. I mean, a visit with a nutritionist is far more effective than my trying to explain to a diabetic patient what they need to be eating and how. We changed our reimbursement model to be able to reward practices with some upfront payments that they could use. And the way we do it is we case mix the payment. So if there's a practice that has more folks with diabetes or more advanced disease, they get more money up front in the case management stream. And they can use that money to do whatever they want. They could spend more time on email. They could spend more time with nurses doing educational visits. We actually embedded pharmacists and physical behavioral health specialists in practices because every practice was different, and we wanted to make the funds available and the resources available that they could then choose to use as they saw fit. And then we pay certain things on a fee-for-service basis. So, there's a visit that we call the enhanced annual visit, which is particularly effective for seniors, where you can do some case management, care management, design, and really have the time for the conversation so that you understand not only what the patient has, but what their life is like, so you can know what services need to be put in place to help them achieve their goals. And then the last payment stream is for achieving results. And if they get better quality, and we measure them on hypertension control and diabetes control and other factors, and so that brings the right kind of focus so that they're paying attention to these conditions. I mean, as a physician, although hypertension, diabetes are quite prevalent, they're not as sexy as some of these other things that are getting a lot of attention.
Right.
And so a payment model that rewards for excellence for these common conditions really gets the focus back on the team, and it becomes a team effort in the practice to be able to understand who in the practice has hypertension, who's at control, who has diabetes, who's a pre-diabetic, what interventions do we know are going to make a difference. And so that kind of blended payment model begins to create the right kind of feedback, the right kind of focus, and it's helped us to achieve some of the best rates of control of diabetes for any health plan around.
Wow.
Yeah.
Are you saying, Dr. Cropp, that the blended payment model it supports team-based care? It helps clinics either shift to or strengthen their use of team-based care?
Yep, it does. Exactly. Yeah, and if you do it on a case mix um, adjustment, what we wanted to achieve was we wanted the best practices taking care of the sickest people. And so we wanted to create a mechanism so that there wasn't a skimming incentive that
Hmm.
went in the opposite direction. That, wow, if I can really strut my stuff and do a good job of controlling hypertension and diabetes and other conditions, yeah, I'll get rewarded for it. So,
So this sounds to me like exactly where we need to go. And I've had so many conversations with different people in the payer space and the clinician space that I've almost become convinced that it's a bridge too far. I mean, it's out of reach. How have you made it work?
um, you know, one of the other elements that we do pay these docs on is efficiency in terms of the downstream spend that they avoid by taking better care of their patients. And so, typically, depending on the state and the environment, the percent of spend that's going to primary care is maybe 7%, 8%, and so much more is going to specialists and hospitals and pharmacy. But by doing the right things and controlling the health of the population, you're able to eliminate a lot of the downstream care. And we built that into the model so that primary care physicians will be rewarded for excellence and rewarded for the savings that they help to create as well. And so we sat down with a group of primary care physicians almost a dozen years ago now, and said, let's talk about what's working and what's not working in your professional lives. And part of it was they didn't um, they didn't have the wherewithal to put into effect some of the team-based services that we've talked about because they weren't reimbursed. And we said, okay, well, let's fix that. And let's understand if we pay for those kind of services up front, what's the net effect going to be sort of downstream? And how can we structure something that you guys will be incentivized for doing the right work and rewarded for the prevention and the good work that you're doing to avoid the hospitalizations and the other complications downstream? And, we spent 9 months with these guys designing a model that they owned with us. But it took a bit of a leap of faith on our part as a plan. But it was a no-brainer, to go from 8% of the spend or 7% of the spend to 9%, 10%, when you know that you could eliminate, multiples of that downstream. Um, it becomes a no-brainer.
So, how far downstream? I mean, what I'm getting at is we hear all the time that, oh, because of churn in the marketplace, because independent health may have somebody on your books for 3 years and you get their blood pressure under control. So the heart attack that they don't have 4 or 5 years from now, that's saving a competitor some money. So why invest today? How have you solved that, Dr. Kropp? Have you figured out how to capture some of those downstream gains yourselves?
We have, and a lot of that comes from other care management that helps with at-home care that can avoid hospitalization and some of the other areas. So there's enough, as you build the relationship and the trust of the primary care physicians for some of these preventive interventions, it becomes easier to work in partnership with some of the other things. And so as we look at where the near-term opportunities are, um, and they come from reducing hospitalizations, reducing unnecessary specialty imaging, et cetera, you can get some of that back immediately in the near term. And the ability to put a program out there that the physicians will then adopt because you've got their trust, you're going to get some immediate return. And then, for the conditions that, might not manifest itself in a couple of years,
Hmm.
our belief is that, hey, you know, they might become a member of our competitor next year. It's just as likely 3 years from now they'll be back with us.
Ah, okay.
And so
Okay.
you can create the savings in the near term for some of those hospital avoidance and other interventions that are more easily implemented because you've got the trust of your provider partners. And then the leakage, if we can use that term, of the members
Hmm.
who might go to another plan, that'll wash out over the long run.
Interesting. And so, am I hearing you correctly that, at least to some degree, that some meaningful degree, the the notion that all the benefit will redound to someone else because it's so far downstream, that's a red herring, that you've actually kind of cracked the code to capture some of the gain, the shorter term gains from investing in prevention in a time frame that makes sense for
Mhm.
your plan to invest. Am I hearing that right?
Yeah, that's part of it. I think that um, clearly our mission is not for profit, is to improve health. And we know that we do that best in working in partnership with our provider partners, and that the investments that we make on this front, we look at as investments in our members, but also investments in our partners in building that trust. Because so much of what I see um, with interventions that might be brought by other health plans are, it's a great idea that sits on the shelf because it has to be implemented or executed by the provider partner. And the lack of trust sort of doesn't allow for that to happen.
Hmm.
And so at the same time, we're investing in prevention, and we know that there'll be some leakage around that because of churn. The trust enables us to get the full impact of the other interventions that will get us the return that we need in the short term to more than cover the investments that we've made in prevention. Does that help, John?
Sure does. Sure does. So this model that you've developed, where can I find more information about it?
Yeah, we can share that with you. We've got a white paper that we've developed and be happy to share that. We just had our annual meeting with the state and just described that to them, and they're very excited about that as they're looking to figure
Good.
out how do we put more energy into primary care to get the right kind of return on this.
Yes.
Yeah,
Yeah, that's great. So if we can make that available to anyone who's watching or listening to this conversation, I think there will be a lot of interest.
sure. Yeah, absolutely.
Okay. Terrific. Terrific. Um, Mike, we talked earlier about team-based care. What role does shared decision-making have in the model that you've developed and your path toward better cardiovascular risk management?
Yeah. Uh, I chuckle because I think back to when I was in practice and you'd have a great conversation with the patient and then always wonder, okay, when they leave the room, what are they going to do?
Yeah.
What do they own here? And so I think that the recognition that there are more effective ways to communicate and more effective ways to appreciate how much did they understand and how much ownership did they take. But then having the right kind of both technology and then systems to be able to check back in as a reinforcer, it's important. And with diabetes, I think things become a little bit easier because there are more symptoms that people might manifest, and you can begin to tie um, better control to specific symptoms in an individual to remind them that they're doing right. Hypertension, it's a little more challenging, but as you brought up earlier, the availability of home patient monitoring and simple check-ins, and again, deploying members of the team like nurses to be able to make that call, whether it's every other week, once a month, just to remind them and to check in with them and to not just do it in a way that feels like we're just checking in on you, but also to say, what are some of the issues or challenges you're facing?
Hmm.
What else can I help you with?
Hmm.
And so making sure that that the team is well educated in being able to ask the right kind of questions and to understand what other tweaks to the plan might be necessary to help the patient stay on track.
And Dr. Cropp, does your model include community health workers? I think you did mention pharmacists earlier.
We,
Um,
yeah. So we're now building out the community health worker model. We've started in our Medicaid population, and now we're going to be working with some of our community-based organizations to be able to build that out as that workforce is now beginning to expand here in Western New York. And so we want to sort of enable some of the community-based organizations with the right monitoring tools and the right reporting so that they can, in the same way that primary care docs are going to be rewarded, that they can be rewarded for reaching more people and bringing more under control as well. Yep.
and what about pharmacists?
Pharmacists, yeah, we have made pharmacists available to practices that have enough scale so they can be embedded. And that has worked well. And then we tend to be a better partner to the community pharmacists as well here. We have our own pharmacy benefit management company that we've been running for 20 years, and we recognize the important role of the pharmacists. And so, um, while I am not aware of any specific incentive programs that we run that are directed to pharmacists, we're very attentive to, making sure that they get the information that they need and that we're not doing the hurtful things that some of the larger pharmacy benefit management plans are doing with clawbacks and other things. So we've maintained a good relationship with them, and our pharmacy benefit management and specialty pharmacy company um, are incredibly responsive and available with issues that come up with the pharmacist as well. But I do think that going forward, there's going to be an opportunity and probably a responsibility to figure out how to engage pharmacists with some incentive programs because their reach is far greater and more consistent than what we see
Hmm.
in the primary care touches that our members have.
And is that in addition to a reach extending opportunity? Is it also an efficiency opportunity?
I don't know. We'll have to take a look.
Okay. Okay.
Excuse me. Yeah.
Well, gosh, this is fascinating. It's exciting to hear about your model. I'm eager to dig deeper into it and learn more. I'm sure other folks are as well. And I'd love to carry this conversation on for another half hour. Unfortunately, we're coming up to the end. So, Dr. Cropp, as you look ahead over the next 1, 2, 3 years, what innovations or policy changes do you think hold the most promise for improving cardiovascular outcomes?
Well, this might be a pipe dream, but I'll say it anyway. I think that state health departments should begin to think about, um, particularly, for the Medicaid population, um, tying some of the reimbursement rates that are going out to demonstrated better control of the risk factors of cardiovascular disease. CMS might want to take a look at that in terms of what they fund the states at as well. But you can't manage what you don't measure.
Right.
And if you're not managing, you won't improve it. And if you're not creating the right kind of focus on it, it won't get measured,
Hmm.
managed, and improved. And so I think
So, what would that look like in practice? How do you envision that working?
that at the state level, which I think is probably where most of the measurement is occurring, that there are metrics around hypertension control and for a population that is accountable under a Medicaid contract. It's not just that you've um, got the number of folks who have hypertension measured, but you also need to account for the fact that you don't know what you don't know, and what percentage of the population has, their blood pressure measured. So,
Right. Right.
what percent is measured, what percent is controlled, and then, you know, um, I'm just thinking that, in New York State, which is a little bit richer than other states, a $400 per month payment for a Medicaid population, you know, it could be that you want to put a percentage of that at risk for not meeting a certain standard for the percentage of patients who have their blood pressure measured and their blood pressure controlled, or you could layer something on top of it. Either way. Um,
Okay.
but
And
I
would there
think
be a way to, you referred early in our conversation to skimming. Would, is there a way to prevent that from occurring here?
I think that with what we see with the prevalence of diabetes and hypertension, that risk is not going to be as big of an issue.
Yeah.
Yeah, yeah,
Okay.
yeah.
And what about high lipids, high LDL cholesterol?
I think
Another.
you could do the same thing. Yeah,
Okay. Okay.
absolutely.
All
But I
right.
I think that there should be some policy that really focuses on making sure that we're measuring the broad populations and that we're rewarding those entities that are doing a better job of measuring and controlling.
There you go. So taking a system that is rife with perverse incentives, flipping the script and channeling the incentives toward increased investment in prevention and a reduction in downstream treatment of acute cases or even later stage, more costly and more burdensome cases of cardiovascular disease, metabolic disease. That sounds like exactly what we want to accomplish.
Exactly. And there's plenty of literature out there to suggest that this is real. And there have been smaller scale initiatives that have proven this to be effective. So Yep.
All right. Well, thank you for sharing your model with us. And this has really been an inspiring conversation. So it you, you've added to the hope that I have for a brighter, healthier future, Dr. Cropp.
Happy to be a part of this and eager to learn as much as teach. So,
Thank you. Thank you. And before we go, I want to also thank you for your leadership at the Value and Access Collaborative for several years as first a steering committee member and then as chair of the steering committee. You've contributed a lot, not only through the work that you're doing today at Independent Health and in these collaboratives in Western New York, but also through your servant leadership time with the Value and Access Collaborative.
well, thanks for that opportunity, John. It was truly a privilege to work with such a great group.